Hi, welcome to cardiogenic shock. The exchange of oxygen and nutrients at the cellular level is essential for our life. When a cell experiences a state of hypoperfusion, the demand for oxygen and nutrients exceeds the supply at the microcirculatory level. So no matter what kind of shock you're talking about, the end result is this imbalance in supply and demand for oxygen. Cardiogenic shock is a low blood flow type of shock. The definition for cardiogenic shock is either systolic or diastolic dysfunction and compromised cardiac output, so it's an issue with the heart itself, either pumping or filling adequately. So what happens during systole? We know the heart is going to be squeezing blood out to the body. And what happens if the heart cannot squeeze right? Well, you're going to get less blood pumped out. So, and what happens if the heart is thickened? You have less blood that enters the chamber because it's so thickened, and so still less blood pumped out. With systolic dysfunction, the heart cannot pump the blood forward properly. Usually the left ventricle is affected because systolic pressure is greater in the left ventricle. Systolic dysfunction on the right side of the heart would cause blood flow to be less to where? Pulmonary circulation or the lungs. The main cause of systolic dysfunction is acute MI. So let me say that one more time. The main cause of systolic dysfunction is acute MI, and cardiogenic shock is the leading cause of death from acute MI. There are other causes of cardiogenic shock like dilated cardiomyopathy. On the left, that's the picture it's showing. And then way over on the right is hypertrophic cardiomyopathy. Also blunt cardiac trauma, like hitting the steering wheel, severe pulmonary hypertension, and other metabolic issues can cause myocardial depression like diabetes. Diastolic dysfunction, that's where the heart is not filling properly. So in this picture, one cause is being diastolic heart failure, and it means the heart is stiff, and so it can't fill correctly. It cannot fill up with a normal amount of blood during diastole, and so this leaves less to be pumped out during systole. And then there's other causes of diastolic dysfunction, like cardiac tamponade, ventricular hypertrophy, and cardiomyopathy. Also, there are dysrhythmias and structural factors that can cause cardiogenic shock. So if you have very slow or very fast dysrhythmias, you're not going to get enough blood flow pumped out. With structural problems like valves that are stenosed, very stiff valves or valves that are stretched out and very floppy with regurgitation, you're not going to get enough blood flowing through them correctly. So there's either too little through the stenotic valve or regurgitation from an incompetent valve, or the valve doesn't close properly, or it's too flappy so it leaks. So think on this occasion, think of acute mitral regurg and acute aortic regurg and how you already learned that they can be emergent issues because they lead to cardiogenic shock. Also, the amount flowing forward is not going to be enough and it's reduced, and so that's just a serious situation overall. So no matter what the cause is, the patient experiences impaired tissue perfusion and cellular metabolism with cardiogenic shock. Let me say that again. No matter what the cause is, the patient experiences impaired tissue perfusion and cellular metabolism with cardiogenic shock. The early clinical presentation with cardiogenic shock is similar to that of a patient with acute decompensated heart failure. Now remember, this is a low flow shock. The heart's inability to pump blood forward means that you're going to have a low cardiac output, less than 4 liters per minute, tachycardia, hypotension, systolic blood pressure is going to be less than 90 for hypotension, narrowed pulse pressure, increased myocardial oxygen consumption, so the heart is trying to work a lot harder with less oxygen. On physical assessment, you get tachypnea, pulmonary congestion, pallor and cool clammy skin, decreased capillary refill time, and as shock progresses, anxiety, confusion, agitation, decreased renal perfusion, and decreased urine output. Shock's put into three stages that are clinically apparent: compensatory, progressive, and irreversible. So the initial stage, because it's at the cellular level, we don't really have any clinical signs to show that it's there. Metabolism is changing from aerobic to anaerobic, and the important thing about that is lactic acid starts accumulating and causes the body and the blood to have to remove it, and it breaks down by the liver. So that makes need for more oxygen to take care of these lactic acid accumulates. So again, we can't see this happening because it's at the cellular level. So in the compensatory stage, we start to see some signs, and it becomes clinically apparent. Let's see. There's an imbalance in oxygen supply and demand. We're trying to overcome consequences of this anaerobic metabolism. So the classic sign is a drop in blood pressure. So then think about the sympathetic nervous system, what happens with that response to decreased blood pressure. Vasoconstriction, which means blood to vital organs is maintained but decreased from the rest of the body. So decreased blood to the kidneys makes the renin-angiotensin system activate. That increases venous return to the heart. So the GI, the skin, and the lungs are all getting less blood. So we see impaired GI motility, risk for paralytic ileus, cool clammy skin, and air in the lungs that is dead space, so it can't participate in gas exchange, so that decreases O2 levels and increases the rate and depth of respirations. Also, myocardial oxygen demands are increased. If this perfusion deficit is corrected at this stage, the patient can recover, and if not, then we go to the progressive stage. So this starts when compensatory mechanisms are starting to fail, and changes in the patient's mental status are kind of the important findings that know we're going into this stage. The hallmarks are decreased cellular perfusion and altered capillary permeability. So you have increased systemic interstitial edema, you have a decrease in blood pressure, decreased coronary artery, cerebral, and peripheral perfusion. You have anasarca, which is diffuse profound edema. Respiratory-wise, the fluid's moving from the pulmonary vasculature to the interstitium into the alveoli, so we have tachypnea, crackles, and even pulmonary edema. Bronchoconstriction, increased work of breathing. As the cardiac output begins to keep falling, you have hypotension, weak peripheral pulses, and ischemia in distal extremities. So then the GI, the kidney, the liver, the mucosal layer in the GI system is ischemic, so you have ulcers, bleeding, risk of bacteria going across this bleeding area for increased infection. You can't absorb nutrients. Your kidneys aren't working well with ischemia, so you have really decreased urine output. And also you're going to have an increased BUN and creatinine. And we have metabolic acidosis because the kidneys aren't able to clear acids, especially lactic acid, and not reabsorbing bicarbonate either because they're not working. Then the liver can also be having problems because it can't metabolize drugs and waste, so you get jaundice and loss of immune function, so your risk for significant bleeding goes up. Now, if you get to the irreversible stage, which is the final stage, the decreased perfusion from peripheral vasoconstriction and decreased cardiac output really exacerbate the anaerobic metabolism. So there's profound hypotension and hypoxemia, worse tachycardia, organ systems are starting to fail, and once one goes, it's like dominoes, the others start to go, and recovery is unlikely. And you have worsening myocardial depression and a further decline in cardiac output, a lot of waste products are accumulating, lactate, urea, ammonia, and CO2, because liver, lung, and kidney aren't working. And then there's a table on page 1639. It shows the stages of shock really well. You guys have had this before, and I'm really just focused on cardiogenic shock more than I am the stages. So just what I've really emphasized to you is what you should know versus just the actual stages themselves. So you want to look at the lab findings. History and physical is important. They look at lactate, 12-lead, chest x-ray, and of course hemodynamic monitoring if you're in any kind of stage of shock is going to be necessary. So you want to be able to identify the patients that are at risk for shock. So that would be putting the history, physical exam, clinical findings to figure out actually what is causing this oxygen and ventilation hemodynamic instability, and provide interventions to fix that so that they don't have decreased perfusion. You want to protect target and you want to protect end organs from dysfunction, and we want to support oxygen and mechanical ventilation if we need to get their SAT greater than 90. And we want to do activities so that we can conserve oxygen, and we want to use drugs to support the cardiac output. So they're going to need mean arterial pressure greater than 60, and we want to keep them from going from the progressive stage to the irreversible stage. So in cardiogenic shock, what are we going to do if it's from an acute MI to restore blood flow? That's the thrombolytic therapy, get them to a cath, see if they need a stent, or maybe they need other kinds of revascularization. They would get thrombolytics if there's no cath lab around. So then if it's from acute aortic regurg or from mitral regurg that's acute, they would need valve repair or replacement. Remember, if it's an acute situation with those two, it's much more serious. Acute pericarditis can lead to cardiac tamponade. So you would need a pericardiocentesis. That's where they put the needle and decompress the pericardial sac so that it's not full of fluid and keeping the heart from pumping. And while you're getting to the point where you're going to do these interventions, you have to optimize the patient's stroke volume and cardiac output. So they'll be in the ICU, they'll be hemodynamically monitored, and they may get things like intra-aortic balloon pump or ventricular assist devices, and also they may be thinking about cardiac transplant. This is just an overview of the end of what to do when you get somebody from that teetering progressive stage to try and keep them from going to the irreversible stage. One thing people forget about, I think, is early nutrition. Enteral feedings have been shown to enhance the perfusion of the GI tract and maintain integrity of the gut mucosa. So if you initiate enteral nutrition early in, within the first 24 hours, they really have a much better outcome. That is all I have on that. Thank you for listening.